If you just count bodies, you can't get to all-cause mortality. So it means you can find out how many dead, but you can't figure out how many had typhoid, and how many had meningitis, and how many were run over by automobiles, and that kind of thing. And it is not possible to move from hospital rate reports to national figures. An example in this country with a very good vital registration system, which, by the way, became complete only in the 1970s. We collect all this information, and yet, when we want to know how many people and death rates, what do? We have a national census, because there is nothing that beats going out to the population and asking. That's the gold standard of estimating populations and deaths and so forth. Okay, we have many ways. If we have a small area, we can go to every place and say how many deaths were in your family, but there are not many situations like that. Otherwise, we have to do sampling. And much of public health is all about doing surveys. There's a number of things that we have to go through mathematically. We have to decide how many people we need to sample. And the number of people we need to sample is not related to the overall population. This is hard for many non-statisticians to grasp. If you reach a certain number, that number will give you validity whether the population is 100,000 or 500,000 or 1 million. That same number of samples will give you the correct answer. And in our case, in Iraq, we decided our sample size as adequate to measure a doubling of the mortality rate before the invasion. And so we had calculated that up, and we figured that if we got about 9,000 or 10,000 individuals, we would have had enough to measure a doubling. Now, if we wanted to measure a 5% or 10% increase over the pre-invasion figures, we would have had to have a larger sample size. But we felt, for our purposes, if we measured it to double, that would be adequate to prove the consequences of the conflict. And then we have to figure out, where are we going to find these people? Because if you just go to certain places, you can get your numbers easily, but it's not representative for the whole country. So in sampling, we have a principle called sampling proportion to population size. So that means bigger places get more samples than smaller places. And that way it's representative of the whole country. And I'll come back to that in a minute. So here was our first attempt, 2004. Something Les Roberts and my colleagues in Iraq and myself were involved with. And we did this in 2004, and we sampled from 33 locations. And this, in our sampling terminology, is what we call clusters. So we visited 33 places, and in each of those places, we visited 30 households. And we had rules about collecting this information. And we ended up with 988 households and almost 8,000 persons. And in order to be counted as a death, you had to have lived in that household for 3 months before the survey. And that prevented us from double counting. So somebody who lived in 3 or 4 houses with aunts and uncles and cousins and so forth, they didn't get counted. They got counted only in the place where they lived for 3 months. So in some ways, this might underestimate the total number. So that was our figures for 2004. The causes of death, and then from the causes of death and the number of deaths, we calculated a rate. So if we visited 1,000 households and we found so many deaths, then we calculated how many deaths per 1,000 people. And then we took that number and applied that number to the overall population of the country. Now, how do we know how many people smoke cigarettes and are overweight and have high blood pressure in this country? Have we measured everybody? No. We do the same kind of thing. We do a sample and we say, okay, we sampled so many men over the age of 20, therefore the rate is this so much, and then we apply that to the whole population of males in the US of that age. So that's the basic approach we did. And the first thing to do then was to locate where these 30 households were in each of the clusters that we did. And what we had found was, before the invasion there were 46 deaths, and after the invasion there were 142 deaths. And our calculations were that this made a crude mortality rate, which means a gross or overall all-cause mortality rate, of 5 per thousand, and afterwards it went to 7.9 per thousand. Before the war, 2% of the deaths were violent. After the war, 51% of the deaths were from violent causes. Now, we had a real problem because one of the places we sampled was Fallujah. And this was before the massive bombing of November 2004. And there were so many deaths in Fallujah. This was a huge problem. And we tried to figure out mathematically how are we going to handle this. And in the end, we tossed out the Fallujah data because it skewed the results so badly that we thought we would be erring on the conservative side and toss the data out. So we estimated that at least 98,000 people had died, and probably over 100,000 by 2004. So this was the death composition before the invasion. 2% were violent deaths, and this was afterwards. 51% were violent deaths. So that's the overall figures that we found in 2004. Now, the chance of the death rate being less than 98,000, the chance of it being less than 44,000 was 10%, and the chance of it being less than 8,000 was 2.5%. So we have what we call confidence intervals. And we know that the correct answer is someplace between these two limits. And we had very wide confidence intervals in the first survey, and we got a lot of attack from people who didn't understand about that. But this was what Fallujah looked like. So it was easy to understand how, if we'd added Fallujah in, it would have skewed things way up this way, and it probably wouldn't have been representative for the country as a whole. Okay, so here's our 2006 survey. And we had more clusters. We had 47 clusters. We did a year of serious thinking about how to sample. And we consulted key famous demographers, famous biostatisticians, and so forth. So we got the best advice. And this is what we ended up with. We had now 40 households per cluster instead of 30, and we ended up with 12,000 instead of 9,000 individuals. And we finished up by July of 2006. And as I said before, we sampled according to where the population was. So there were 12 samples or 12 clusters in Baghdad. We come down here to Karbala, and we had one there, proportionate to the size. So here's our 47 clusters. Then we had to figure out where they were. We assigned them to the various governors, and then we had to find the house that we went to. So here's our team. And they went to the houses, they get causes of death, dates of death, and details. But many households were a bit hesitant to tell us too much about the details. So we asked about death certificates. So after a household told us that somebody had died, we said, and by the way, do you have a death certificate? And in 92% of the households where we asked, the family had a death certificate. And I can think of no other place in the world that would produce this kind of data. But this is a great argument for people who said families made up the data on deaths. I mean, the chance of people all over Iraq faking death certificates just because a Hopkins interviewer might come, is pretty remote. So more likely, people did not report deaths. It's a more likely situation. So that would mean that our estimate was actually a bit on the low side. But we'll talk about that in a minute. Okay, so overall, we ended up with these numbers. We had an overall estimate of 650,000 excess deaths. The chance of it being less than 500,000 was only 10%. The chance of it being less than 390,000 was only 2.5%. So this represents what we would call the confidence interval, and we know that between this side and this side, which is 940,000, the true figure has a 95% chance of being in here, and this one is the most likely number to be there.